Imagine, for a moment, a tiny hidden air pocket deep in your throat. It's linked directly to your ears. Now, this little space is meant to help with breathing, vocalizing, but for horses, this isn't just, anatomy. It can become a place where pus actually accumulates, creates a real health crisis. Today, we're taking a deep dive into equine guttural pouch empyema. We've got some specialist level source material here of a study guide, really reflecting the latest understanding and management strategies. We're going to unravel this.
Exactly. Yeah, at its core, equine guttural pouch empyema is basically characterized by that accumulation of purulent material pus within these really unique guttural pouches. It's a pretty significant condition in equine health, definitely.
Right. So our mission today is to really pull back the curtain on this often misunderstood equine ailment. We'll explore its really unique anatomy, understand how it gets diagnosed, delve into the incredibly demanding treatment it often requires, and ultimately why it presents such a persistent challenge for vets and horse owners alike. You'll see how a seemingly simple symptom can be, well, the tip of a very complex internal problem. So let's unpack this anatomy first. It's truly unique, isn't it?
Oh, absolutely. Guttural pouches are these remarkable paired, air-filled outpouchings, diverticula technically,
Right.
of the horses eustachian tubes, the tubes connecting the middle ear to the throat.
Right, we have those two, but not the pouches.
Exactly. And here's the kicker. You find these structures only in equids.
Only. So just horses, donkeys, mules.
That's it. They are genuinely one of a kind in the animal kingdom.
Wow. Okay.
And inside each pouch, there's this bone, the stylohyoid bone. It acts like a natural partition,
Yeah.
divides it into a bigger medial compartment and a smaller lateral one.
And does that division matter?
It really can. Yeah. As we'll see, it can sometimes complicate things when it comes to drainage and treatment.
Okay. And here's where it gets really fascinating and maybe a bit alarming. These pouches are packed, absolutely packed, with vital structures.
Incredibly so. It's like a neurological and vascular junction box in there. We're talking crucial cranial nerves.
Which ones are we talking about?
Well, you've got the glossopharyngeal, that's 9, the vagus, 10, accessory, 11, hypoglossal, 12. Even parts of the facial nerve and the sympathetic trunk run through or right next to the pouch wall.
Good grief. That controls swallowing, facial movement.
Swallowing, breathing, heart rate regulation, facial expression, tongue movement. It's all in there.
And arteries, too, right? Major ones.
Oh, yeah. The internal and external carotid arteries, the maxillary artery, big, important blood vessels. It's critical real estate, basically.
Yeah.
Very busy, very vulnerable.
So with all that crucial stuff inside, do we even know what the pouches are for?
That's still debated, actually. The main theories are, 1, they might help cool the brain during heavy exercise.
Ah, like a radiator.
Sort of, yeah, cooling the blood going to the brain. And 2, they might act as resonance chambers for vocalization.
Helping with those big whinnies.
Could be, yeah, giving them that power and resonance.
Okay, so when we talk about guttural pouch empyema, what exactly is that?
Right, so empyema just means the accumulation of pus. In this case, it's that pus-filled material building up inside one or sometimes both of these pouches.
And what's causing that pus? Is it always infection?
Overwhelmingly, yes. The primary culprit is almost always a bacterial infection, usually secondary to something going on in the upper respiratory tract.
Okay, secondary. So what's the primary infection usually?
By far the most common cause, like really the big one, is Streptococcus equi, subspecies equi.
Strangles.
Exactly, strangles. And the link is quite direct and, frankly, concerning. In strangles cases, you get these lymph nodes at the back of the throat, the retropharyngeal lymph nodes. They're right next to the pouches. These nodes can form abscesses, and those abscesses can actually rupture.
Oh, wow.
And drain directly into the guttural pouches. And boom, you've got pus filling the pouch.
So the strangles infection basically spills over.
Precisely.
No.
But it gets even trickier. Horses can recover from strangles, but become asymptomatic carriers. They harbor the S. equi bacteria within their guttural pouches without showing any outward signs themselves.
So they look healthy, but they're shedding bacteria.
Exactly. They can be a hidden source of infection, spreading strangles to other horses. It's a huge biosecurity headache.
Yeah, I can imagine. Are there other bacteria involved besides strangles?
There are, though less common. You might see other Streptococcus species like Strep zooepidemicus or sometimes Pastorella. But honestly, regardless of the specific bug, a key part of the problem is often impaired natural drainage.
How so?
Well, the pouch has a small opening into the pharynx. If there's inflammation or swelling, maybe from the initial respiratory infection, that opening can get restricted or blocked.
Ah,
So normal secretions get trapped inside, they can't drain out. And that stagnant fluid is just a perfect breeding ground for bacteria. Pus accumulates.
and then in chronic cases, this pus can change, become something else.
Yeah, if it sits there long enough, the purulent material can start to dry out, thicken up, condense, and it forms these firm, sometimes quite hard, rounded masses. We call those chondroids.
Chondroids, like guttural pouch stones.
That's exactly what people often call them, and they're a real problem
Why are they so bad?
because they act like a persistent reservoir of infection. Bacteria live inside them, and they're physically hard to get rid of. They're often lodged deep in the pouch, solid, stuck in there.
Making treatment much harder.
Much harder, yeah.
Are there any other, like, really rare ways this can happen besides infection?
Very uncommon, but yes.
Yeah.
Occasionally you might see it if, say, someone accidentally infused an irritating substance, or maybe a foal is born with a narrowed pouch opening, a congenital stenosis,
Okay.
or even a fracture of that stylohyoid bone we mentioned, or rarely if the pharynx gets perforated during tubing, like with a nasogastric tube.
Right, an accident during a procedure.
Yeah. But honestly, 95+% of the time, you're looking at a bacterial infection, usually linked back to strangles or drainage issues.
Okay, so given all this complex anatomy, the infection risk, the chondroids, how does this actually show up? What are the signs? What are the red flags owners or vets should look for?
Well, the clinical signs can really vary. Depends on severity, how long it's been going on, whether one or both pouches are involved. But the most common sign, the one you see most often first, is a purulent nasal discharge.
Okay, pus coming out the nose.
Exactly. And it's often pretty distinctive. It might be creamy white, maybe yellowish, sometimes greenish. It often comes from just one nostril if only one pouch is affected, but it can be bilateral.
And does it just drip constantly?
It can be intermittent,
Yeah.
but often you'll see a lot of it, like quite copious amounts, especially when the horse lowers its head.
Ah, like when eating or drinking. Gravity helps it drain out.
Precisely. And the crucial thing here, especially if strep equi is involved, is that discharge is highly infectious.
Right, so it's not just messy, it's a biohazard.
Absolutely. Big time.
What else might you see?
You might notice swelling, often in the throat latch area or the parotid region that's sort of behind the jaw, below the ear.
Is it tender?
Yeah, it can be painful, maybe feel a bit fluid-filled on palpation, and large lymph nodes nearby are also common.
Any systemic signs? Like fever?
You can, yeah, especially if the infection is more acute or severe, fever, maybe some depression, lethargy, just not feeling right. Some horses might hold their head stiffly, maybe because of the pain or swelling. And you might hear respiratory signs, like a moist cough or sometimes stertorous breathing.
Stertorous, what's that sound like?
It's kind of a snoring noise. It happens if the swollen pouches are actually compressing the pharynx, narrowing the airway.
Okay. Now, you mentioned all those vital nerves running through there. What happens if they get affected? That sounds serious.
It is very serious.
Yeah.
The absolute scariest warning sign is dysphagia.
Difficulty swallowing.
Exactly, difficulty swallowing. While it's less common than the nasal discharge, it's critical because it means those cranial nerves are being compromised.
Nerves 9, 10, 11, 12.
Primarily those, yes. The glossopharyngeal, vagus, accessory hypoglossal, they control the whole swallowing mechanism. If a horse can't swallow properly, that's a potentially life-threatening situation due to risk of aspiration, pneumonia, and malnutrition.
Wow. Okay. And what about those silent carriers you mentioned? Do they show any signs?
That's the really tricky part for herd health. Horses with maybe just small chondroids or those chronic S. aqua carriers, they might show no obvious clinical signs at all.
None.
Maybe a tiny bit of intermittent discharge that goes unnoticed,
Yeah.
or maybe literally nothing you'd pick up on casually. Yet, they can still be shedding bacteria, acting as a persistent source of infection for other horses.
Man, that makes control difficult.
Extremely.
So, faced with these signs or maybe suspicion of a carrier, how do you actually confirm it? What's the diagnostic process?
Well, it always starts with a good history, asking about any previous respiratory issues, especially strangles, vaccination status, contact with other horses, then a thorough physical exam. Really carefully palpating that throat latch and parotid area for any swelling, heat, pain, or enlarged nodes. Listening carefully to the breathing.
But that only gets you so far, right? You need to see inside.
Exactly. The undisputed gold standard for diagnosis is endoscopic examination.
Sending a camera up the nose?
Pretty much, yeah. A flexible endoscope is passed through the nasal cavity, into the nasopharynx, and then you carefully guide it into the opening of the guttural pouch.
And what can you see in there?
You get direct visualization. You can see if there's pus, fluid lines indicating fluid levels. You can spot those chondroids, assess the inflammation of the pouch lining. It's incredibly informative.
And you can take samples, too.
Absolute critical part. You can pass instruments through the scope to collect samples of the pus or lavage fluid directly from the pouch. Essential for culture and PCR.
Okay. What about imaging? Does that play a role?
It does, yeah. It's a very useful supporting tool. Skull radiographs, x-rays can be helpful.
What views do you take?
Usually lateral, oblique views, sometimes ventrodorsal. They can confirm those fluid lines you see distinct air-fluid interface. And they can reveal radiopaque chondroids. They often look like little stones or calculi on the x-ray.
So x-rays are good for seeing fluid and stones. What about more complex cases?
For really complex or chronic cases, or if you suspect subtle chondroids the scope might miss, computed tomography CT is fantastic.
The CT scan.
Yeah, it gives you excellent 3D detail, really helps delineate the full extent of the problem, pinpoint small chondroids, see if surrounding structures are involved. It's much more sensitive than X-ray for this.
And then the lab tests on those samples you collected.
Crucial. You send the guttural pouch lavage fluid or swabs for bacterial culture and sensitivity.
To see what bug it is and what kills it.
Exactly. And you always specifically ask the lab to culture for Strep equi, subspecies equi. We also run PCR tests for S. equi DNA. PCR is super sensitive, especially for picking up those low-level chronic carriers that might not culture positive.
Okay. And blood work.
Blood work can give general clues. You might see signs of inflammation or infection, like an elevated white blood cell count, but it's not specific to the guttural pouch. The direct pouch samples are key.
Right. So diagnosis made. We know there's empyema, maybe chondroids. Now the hard part, treatment. This sounds like a long road.
It often is, yeah. It requires significant commitment from everyone involved. The main goals are pretty clear, though. 1, get the pus out. 2, kill the bacteria. 3, restore normal drainage so it doesn't just fill up again.
And you said antibiotics alone aren't enough.
Absolutely not. That's probably the single most important treatment concept here. Because of the sheer volume of pus and debris, especially if there are chondroids, systemic antibiotics just can't penetrate effectively enough on their own. The cornerstone, the most critical step, is mechanical removal of that material through guttural pouch lavage.
Flushing it out.
Repeatedly flushing it out. It's essential.
Okay, walk us through that lavage process. It sounds involved.
It is. It's done with the horse sedated, of course, for safety and comfort. You pass the endoscope into the pouch so you can see what you're doing. Then you advance a special lavage catheter, often something like a Foley catheter with an inflatable cuff, or a specific Chambers catheter designed for this.
Right.
And then you infuse large volumes, and I mean large, like 2 to 4 liters at a time of warm, sterile saline solution into the pouch.
2 to 4 liters. Wow.
Yeah, you fill it up, let it sit for a moment maybe, and then allow it to drain back out, carrying pus and debris with it. You repeat this cycle until the fluid coming out looks relatively clear.
Are there any, additives you put in the saline? Any secret weapons?
Sometimes, yeah. If the pus is really thick, or there are suspected chondroids, we might add acetylcysteine. The brand name is Mucomisty.
What does that do?
It's a mucolytic agent. It helps break down thick mucus and can help soften or dissolve the matrix of chondroids, making them easier to flush out or break up. Occasionally, very dilute antiseptics like povidone iodine might be added to the lavage fluid, but you have to be careful not to irritate the pouch lining too much.
And this isn't just a one-time flush, is it?
Oh, heavens no. Persistence is absolutely key. This lavage procedure often needs to be done daily, or maybe every other day.
Daily? For how long?
It can be for several weeks, sometimes even months in chronic cases or with chondroids. You continue until repeated endoscopic exams show the pouch is completely clean and healthy looking.
Months of daily flushing. That's a huge commitment.
It really is. And it's tough on the horse, the owner's schedule, and the wallet.
What about those chondroids? Can you always flush them out?
Small ones might flush out with repeated lavage, especially if you're using acetylcysteine, but larger, firmer ones often won't. They might require mechanical fragmentation first. You can try to break them up using endoscopic tools like biopsy forceps or specialized graspers, or even laser.
Break them into smaller pieces to flush out.
Exactly. Or sometimes they're just too big or too hard, and they require surgical removal. And one important note from the sources: avoid using really high pressure or excessively large single volumes during lavage. There's a risk, albeit small, of actually rupturing the pouch.
Good point. Okay, so lavage is king. Where do antibiotics fit in?
They're still very important, but they work in conjunction with the lavage. Systemic antibiotics are prescribed based on those culture and sensitivity results we got.
So you target the specific bacteria?
Precisely. Common choices, especially if strep equid is involved, include things like penicillin G, trimethoprim sulfamethoxazole, TMS or SMZs, or ceftiofur.
And how long do they stay on antibiotics?
Typically, treatment continues for a decent period after the pouch looks clear on the scope, usually about 2 to 4 weeks post-clearance. You really want to make sure you eliminate any residual infection that might be hiding.
Makes sense. What about supportive care? Making the horse feel better?
Yeah, that's important too. NSAIDs, non-steroidal anti-inflammatory drugs like phenylbutazone or flunixin are used to manage pain, reduce fever, and decrease inflammation in the pouch and surrounding tissues. Some vets might also use oral mucolytics to help thin secretions generally in the respiratory tract.
And biosecurity remains crucial, right? Especially with strangles.
Absolutely paramount. If strep equi is confirmed or suspected, strict isolation of the affected horse is non-negotiable. That nasal discharge is incredibly infectious. Good hygiene, separate equipment, careful handling, all essential. And actually, even just feeding the horse from the ground rather than a high hay net can help.
How does that help?
It encourages a more natural head-lowered posture, which uses gravity to help facilitate drainage from the guttural pouch openings in the pharynx. Simple, but potentially helpful.
Interesting. Okay, so you try medical management, lavage, antibiotics, supportive care. When does that fail? When do you have to say, okay, we need surgery?
Surgery becomes the next consideration if medical management just isn't resolving the infection after a reasonable, persistent effort. Or if there are very large chondroids that you simply cannot flush out or break up endoscopically, and also if there's severe airway obstruction caused by the swollen pouches that isn't responding to medical treatment.
What are the surgical options? Can they still try to use the endoscope?
Sometimes, yeah. For some larger chondroids, they might attempt endoscopic-assisted removal, using stronger forceps or snares passed through or alongside the scope to grasp and remove or fragment the chondroids. It's less invasive than open surgery.
But sometimes you have to cut.
Sometimes, yes. The main open surgical approach is called ventral drainage. This involves making a surgical incision into the guttural pouch from underneath the neck, the ventral aspect.
To physically go in and clean it out.
Exactly. Allows the surgeon to manually remove large or numerous chondroids and debris, and importantly, it can create a larger opening for ongoing drainage.
But you said that area is packed with nerves and arteries. That sounds incredibly risky.
It carries significant risks, absolutely. There's potential for damaging those cranial nerves we talked about, which could lead to permanent swallowing problems or other deficits. There's risk to the major blood vessels, too. It's not undertaken lightly.
Yeah, I bet. Any other surgical considerations?
In really severe cases where the horse has significant airway obstruction and difficulty breathing, a temporary tracheotomy might be necessary.
Putting a tube directly into the windpipe.
Yeah, creating a temporary bypass airway in the neck until the swelling in the pharynx and guttural pouches subsides enough for them to breathe normally through their nose again.
Okay. And circling back to those carriers, the ones hiding S. equio, how do you manage them? Is it just more lavage?
It's essentially a very aggressive and prolonged version of the medical management. Aggressive, repeated lavage, sometimes with acetylcysteine or antiseptics, and often targeted, maybe even local, antibiotic therapy based on sensitivity testing, sometimes infusing antibiotics directly into the pouch or using things like penicillin gel that sticks around longer.
And the goal is complete clearance.
Complete clearance. It's crucial not just for that horse's health, but to stop them from being a source of strangles outbreaks. You need proof of clearance, usually through multiple consecutive negative PCR tests or cultures from pouch washes, typically taken weeks apart before you can confidently say they're no longer a carrier.
That sounds like another long and potentially frustrating process.
It definitely can be. Carrier status can be very stubborn to resolve.
So let's talk outcomes. What does the future look like for a horse after going through all this? What are the lingering risks or complications?
Well, one major potential complication is that chronic carrier state for escobate that we just discussed. If treatment isn't fully successful, they can remain a risk for spreading strangles. Another is persistent airway obstruction. Even after the infection clears, some scarring or thickening might remain, causing noisy breathing or reduced performance.
And those nerve issues, the dysphagia, can that linger?
Yes, and that's one of the most serious potential long-term complications. Neuropathy, nerve damage, due to the inflammation or pressure within the pouch. It might not resolve completely. So dysphagia, difficulty swallowing, or other nerve deficits like laryngeal paralysis, roaring, or facial nerve paralysis can sometimes be permanent or only partially recover.
And if they have trouble swallowing long term, that risk of aspiration pneumonia.
Exactly. That becomes an ongoing concern. Aspiration pneumonia is a very serious secondary consequence. And of course, there's always the risk of recurrence, especially if the underlying cause, like poor drainage or incomplete clearance of chondroids or carriers, isn't fully addressed.
So, tying this all together, what's the overall prognosis? Is it generally hopeful or more guarded?
It really depends on the specifics of the case. For acute cases, caught early and treated promptly and aggressively with lavage and appropriate antibiotics, the prognosis is generally favorable to good. Most horses can make a full recovery.
That's encouraging. But what about the chronic ones?
For chronic cases, or those involving significant chondroids, the prognosis shifts more towards guarded to fair. These cases require that prolonged intensive treatment we talked about, often involving surgery. Chondroids in particular can be really tough to clear completely with just medical management.
And the absolute worst prognosis is if nerves are involved.
Yes, if significant neurological deficits are present, especially dysphagia, the prognosis becomes guarded or potentially even poor. Nerve function might not return sufficiently for a good quality of life or safe eating.
It really underscores how complex this condition is. Which brings us to prevention. How can we try to avoid going down this difficult road in the first place?
Prevention is absolutely key, you're right. And the single most important preventative step, by far, is effective control and prevention of strangles.
Because it's the main driver.
It's the main driver of the most common and often most severe form of guttural pouch empyema. So anything that reduces strangles transmission helps prevent empyema.
What are the practical measures? What should horse owners and barn managers really focus on?
Good biosecurity practices are paramount. That means things like strict quarantine protocols for all new horses coming onto a property, usually at least 2-3 weeks, monitoring for any signs of illness, and immediate isolation of any horse showing signs of respiratory disease, especially fever or nasal discharge. Don't wait. Isolate first.
What about vaccination? We've seen how a common infection like strangles can snowball into this really complex, demanding health challenge. And you've hopefully gained some real insight into the intensive diagnostics, the often laborious treatment efforts required.
Yeah, it takes a lot of dedication from vets and owners.
So you, listening in, you've just got this rapid-fire understanding, really, of a highly specialized equine health issue. And hopefully you realize the profound dedication and intricate knowledge that goes into veterinary medicine. How a simple runny nose isn't always simple.
It can be a tiny window into this incredibly complex, hidden problem deep inside the horse's head.
So as you think about everything we've discussed today, maybe reflect on this. How understanding these really unique, sometimes weird anatomical quirks.
Like the guttural pouch.
Exactly. How understanding those quirks in any animal can lead to such profound insights into their specific health challenges.
Yeah, it really highlights why knowing the why behind a symptom, the underlying cause, the mechanism, is often so much more important, so much more powerful than just treating just the obvious sign you see on the surface.
A perfect place to leave it. Really fascinating stuff.